So good morning, ladies and gentlemen. It is a great pleasure to be here at the 2024 AAO annual session in this wonderful city, New Orleans, with the possibility of watching Mick Jagger live. Isn't that amazing? He's 82 and he's still sexy. Well, before I begin, I would like to congratulate the Board of Trustees of the AAO, most especially Dr. Myron Gimmon, President of this association, who will be ending his term at the end of this meeting and did a fantastic job for the AAO. I would also like to thank the Committee of Congresses and Meetings, especially Matthew Larson, Chair of this program, Nellie Kim, my dear friend, Vice Chair, and our dearest Jay Park, member of this committee, and many others, Carlos Flores-Mir, and I hope I'm not being unfair here with the group. Congratulations with your hard work. My name is Flavia Artese. I am a Brazilian orthodontist. I was born, raised, and I live in Rio de Janeiro, where I received most of my orthodontic education. I share my time between private practice and academics. At the moment, I am the chair of the orthodontic department of the Rio de Janeiro State University. And I also play an active role in orthodontic associations. And my current and maybe my most difficult challenge is to chair the 10th International Orthodontic Congress that will be happening in Rio de Janeiro in October 2025. So I would like to make it clear that I have no conflict of interest in this presentation with the products or anything that I will present, but I would kindly request the audience to preserve the intellectual property of this presentation and most especially the privacy of patients. I am an enthusiastic user of social media. Some of you already follow me. Please post as much as you want, take as many pictures as you wish, but the only thing that I request is please avoid posting patient images. And if you post, by the way, please tag me. Well, human beings developed the capacity of communicating graphically by cave painting, hieroglyphs, the cuneiform writing, ideograms, the Greek alphabet, many different ways of transforming information into codes. Our current alphabet, where we can read masterpieces of literature, of poetry, of romance, and currently, with the digital world, new forms of expressing emotions. We are codifying people and decodifying people. That is the way we express information. And since the beginning of classical art, we have tried to codify beauty through measurements of the face, through anthropometry, and us specifically through cephalometrics. What cephalometrics really does is a codification into shapes and numbers of facial morphology, and in a way transforming what is a three-dimensional image into a two-dimensional image, which may lead to some confusion. So when we talk about the vertical problems, we are basically talking about three aspects that we can act on. The first one is facial proportions. The second one, the amount of overbite. And the third one, a prosthetic aspect, which is the occlusal vertical dimension. In these three areas, we can change the vertical occlusion. And despite this may sound very unusual or awkward to you, these factors are not usually associated to each other. Despite the profession believing that there is an association between facial pattern and the amount of overbite, this is not true. You can see in the screen two hyperdivergent patients, one with an anterior open bite and the other one with a deep bite. So there is no clear association between facial patterns and the amount of overbite. And the same thing happens with interocclusal distance. It's not because we have a long face or a short face that we will have different interocclusal distances. So because of these conventions or because of these ideas, maybe we have many diagnostic factors or many aspects that are scattered as our codes and connected, which leads to misconceptions. And that is why I believe that vertical problems are really not challenging. They are just misunderstood based on misconceptions that we have created along the construction of cephalometric analysis. So what I would like to propose to us today is that together we will look or read the vertical problems in individualized treatment plans, considering basically 5 diagnostic factors that for me are paramount in establishing a treatment plan for the vertical dimension. And these are lower anterior facial height, incisor exposure of upper and lower incisors, posterior alveolar height of upper and lower molars, the amount of overbite, and the amount of occlusal wear of posterior or anterior teeth. So let's begin with our very first aspect, which is facial proportions. Many different ways of measuring facial proportions have been devised. You will find a myriad of analyses trying to describe proportions of the face. But what really matters to us as clinicians is that there's only one region we can change, and that is lower anterior facial height. We cannot change the rest. So this is really the proportion that matters to us. And this is going to become, therefore, our diagnostic factor number 1. Lower anterior facial height can be measured by thirds from the hairline to the glabella, from the glabella to the ala of the nose, and from the ala of the nose to the menton. It can also be measured by a proportion to total facial height. Total facial height is measured from nasion to menton, and 65% of it should represent the lower facial height, which is measured from the anterior nasal spine to the menton. So we will end up having vertical dysplasias when there is a disproportion or a lack of proportion of these thirds. So a long-faced patient will have an increased lower anterior facial height, and a short-faced patient will have a decreased lower facial height, together with other very common characteristics. An increased lower facial height on the long face, a high mandibular angle, and lip incompetence. While the short face will have a decreased lower anterior facial height, low mandibular angle, and overclosure of the lip. And obviously, when the severity or the lack of proportion reaches a certain standard, the only way that they can be properly corrected is through surgical treatment. The problem here is we don't have a clear cutting point of when a case can be treated in a compensatory manner or when it can be treated through surgery. What ends up happening is not only the vertical issue that is considered, but sagittal problems have to be taken into account, and most importantly, the psychosocial impact of the patient. So you really won't have a clear-cutting line, which is usually what the audience wants. Like, give me a number. There's no number. There is an association of numbers that will take you to this diagnosis. But if the decision is surgical, you will have 4 ways, 4 ways of, is the movie running? Yes? We will have 4 ways of correcting these vertical dysplasias. Either by a parallel vertical movement of the maxilla, which could be a maxillary impaction, and this would reduce the lower facial third, or through a maxillary set down, which would increase the lower facial third. You can also decrease or increase lower facial thirds by the bimaxillary anti-clockwise rotation, and this would reduce the lower facial height, or a bimaxillary clockwise rotation, which would increase the lower facial height. What is going to make the decision if we're going to make a vertical movement or if we're going to make rotation of a few factors, the most important one is our second diagnostic factor, which is incisor display at rest. Most importantly, the upper incisor. Incisor display at rest has been very much described in the literature. It can be measured through cephalometrics by the distance from the incisal border to the upper lip, and that should be greater than 2 millimeters for an adequate upper incisor display at rest. And from the tip of the lower incisor to the lower lip, that should be 0 or less for an adequate lack of exposure of lower incisors. You can also use photography with certain syllables like Emma, and even videography with certain phrases that have been described in the literature. So of everything I'm going to speak today, when we're talking about vertical problems, for me, this is the most important clinical aspect that we have to look at. Upper incisor display at rest. This is what gives us youth when we do our current activities. It's not only smiling, it's when we speak, aesthetics of the speech. And it is really, really important. It rules all of my vertical treatment planning. And despite this having been proposed and spoken for many decades, the current literature shows us that it is still disregarded. Nevertheless, how do these vertical dysplasias happen? How does a long face happen and how does a short face happen? It's really a mismatch between the amount of condylar growth and posterior alveolar height. So long faces have a small condylar growth with an increased posterior alveolar height, while short faces will have an increased condylar growth with a decreased alveolar height. And therefore, you're going to have these different rotations of the face. And the reason why overbite is not associated to facial height is because it is more associated to function. So if you have one or the other and you have an anterior open bite, there will be a functional component right there. And you have all seen me talk about it for many times, and I decided not bring this to the matter today. So if we have an increased and decreased posterior alveolar height, is there a chance that we can treat adult patients in a compensatory manner? Are there compensatory treatments for long and short faces? Yes, there are. In contemporary orthodontics, we can use mini implants or mini plates which allow you to intrude molars. Molar intrusion will decrease the lower facial height by a counterclockwise mandibular rotation. On the other hand, a short-faced patient can be improved by molar extrusion through an opening of the bite, extrusion of these posterior teeth, and therefore a clockwise rotation of the mandible. So this is going to be our third diagnostic factor, posterior alveolar height. And how are we going to look at this? Patrick Turley, who is in the audience, developed a cephalometric analysis for the short-faced patient. And I borrowed his measurement of posterior alveolar height, which is the height from the mesobuccal cusp of the molar to the palatal plane, and the same thing for the lower molar to the mandibular plane. And for the upper molar, it should measure around 24 millimeters, and for the lower molar, around 34 millimeters. Just to tell you a short story, last year I was speaking at this session on deep bites, and Patrick Turley was in the audience. When I came back home 3 weeks later, I received a reprint of this paper with a kind note from him telling me that he was very happy to see all the information I was bringing on the vertical dimension, and this was a contribution he would like to share. And reading that paper, he inspired me to put all of this information together that I'm going to be sharing with you today. So Pat, thank you very much. It was really a very valuable contribution. So there is a very clear association with posterior alveolar height and lower anterior facial height. It is a positive correlation, so long posterior alveolar heights is going to increase the anterior facial height, and short posterior facial alveolar heights are going to decrease the lower anterior facial height. So how can we treat these patients compensatorily? Dr. George Faber kindly lent me this case of a hyperdivergent patient with lack of lip seal and a high smile line. She is an asymmetrical class 2 with a deep bite with hyperdivergent characteristics. So let's put all these three diagnostic factors together and see how they can impact on diagnosis. She had an increased lower anterior facial height, an increased upper incisor display at rest, and an increased posterior alveolar height. And this will lead us to the diagnosis of what we're going to do in this young lady. An increased lower anterior facial height could be treated by surgery or by molar intrusion. The increased upper incisor exposure allows us to intrude incisors, and the increased posterior alveolar height will allow us, to intrude molars. So this is what Dr. George Faber devised, a complete upper arch intrusion with skeletal anchorage, using mini plates in the posterior region, intruding the full arch and at the same time distalizing the side of the class 2 with a very robust, I would say, iron casted palatal bar. And this was sufficient to transmit the force or the intrusive force for the whole maxillary arch to this beautiful final result. And when we compare the final results, he did successfully intrude those incisors. He did successfully improve her upper incisor display at rest, and he did successfully perform some counterclockwise rotation of the mandible, which reduced her lower anterior facial height in some proportion. But what do we know about the limits of molar intrusion? This paper published by Paris and collaborators looking at the dental skeletal changes in adults using orthodontic mini implants for molar intrusion found that there is an average of approximately 2.5 millimeters of intrusion in the molar area. And that 1 millimeter of molar intrusion will give us 0.9 millimeters, or would say 1 millimeter of bite closure. And he didn't really see significant skeletal changes. What about the other side of the coin, the short-faced patients? What can we do for them? Can we treat them compensatorily? This young girl presented a short face with a class 3 malocclusion, a negative overjet, and a significant amount of extrusion of her lower incisors. Diagnostic factors: decreased lower facial height, exposure of lower incisors instead of upper incisors, and a decreased posterior facial height. What can we do for this girl? Decreased lower anterior facial height, we can do a maxillary set down, or we can extrude molars. A decreased upper incisor exposure and an increased lower incisor exposure, we can extrude upper incisors and intrude lowers. And a decreased posterior alveolar height, we can stimulate the extrusion of these posterior teeth. So when we manipulated this girl to centric occlusion, we had a large interocclusal distance. And we decided to treat her with bite razors and allow the molars to extrude. So first bite raising, second bite raising, and the second one was asymmetrical because she had an asymmetry and we wanted asymmetrical extrusion. And this is her follow-up. This is how she is currently. Look at her facial characteristics. She improved dramatically. Look at the occlusal characteristics. They improved very much. Profile view, a significant increase in the lower anterior facial height. Frontal view, a significant increase in anterior facial height and a reducal of the overclosure of the lips. And smiling, you can see much more dental tissue now due to the vertical changes that were performed. What happened to her? A clockwise rotation of the mandible, which led to the increase of the lower anterior facial height. But what I want to point out here is something very important. These vertical dysplasias, when they are in the right sagittal component, they can be of help. So every time you have a class 2, if you can intrude, you're going to help the correction of the class 2. Every time you have a class 3, if you can extrude, you're going to help the correction of the class 3. So vertical posterior movements are going to have a sagittal effect that can be used favorably towards your clinical result. And the other thing that is very important to think about is stability. The literature has mapped out the stability of surgical procedures, knowing that maxillary impaction is the most stable procedure, while the maxillary set down is the least stable procedure we have in orthodontic surgery. So maybe this can be an information on clinical decision on what way you're going to go. But what about stability of molar intrusion or extrusion? Molar intrusion with TADS has been largely studied, and there is approximately 12% of intrusion of relapse of maxillary intrusion and 27% of relapse of mandibular molar intrusion. Regarding extrusion of these teeth, we know nothing. So we really do not know how stable this amount of posterior extrusion is. There are very few studies, and they're all very, very old. But what about looking at this in the growing child? Will growth help us in vertical dysplasias, and how can we use it at our favor? Let's have a look at this young patient. He is a hyperdivergent patient with an enormous amount of incisor protrusion. The teeth are sticking out of his mouth. He is a significant class 2 with a very deep bite and a very large overjet. Clinically, we can see that his lower facial height is normal, that he has a very large upper incisor exposure of 10 millimeters, and that the posterior alveolar heights are normal as well. So when we put these diagnostic factors together, what can we do for his facial height? Maintain it. What can we do for upper incisor exposure? Intrude the incisors. And what can we do for the normal posterior alveolar height? Try to maintain it. So we opted to treat this child with a maxillary splint headgear with the intention of maintaining the vertical position of these molars with an intrusive component. Here he is at the end of the first phase of treatment, 2 years of treatment. And this is his occlusion. Significant improvement, but the face did not improve very much. And the reason is we had compensatory extrusion of the lower molars in our natural mechanism of maintaining stable the interocclusal distance. This is something that naturally our body does. So because of this compensation of the lower molar, we obviously didn't see a significant change in his face. There was no mandibular rotation because the lower molar wasn't forbidden to extrude. How did we deal with this in the past? With vertical chin cups. Lloyd Pearson proposed this in the 70s, and all the way to the 90s, this was the idea of holding the bimaxillary vertical dimension by using an intrusion headgear and a chin cup. But I have to confess, I will not have my children today being able to use this, even though it was effective. So Peter Bouchang and his team proposed the idea of using mini implants in growing children to evaluate this hyperdivergent growth. And he treated 9 consecutive patients, 13 years of age, using 1 mini implant in each quadrant with the intention of maintaining these molars in their vertical position. And what he saw was a substantial orthopedic effect. The chin advanced approximately 2 millimeters, the mandibular plane decreased approximately 4 degrees, and the facial convexity decreased approximately 3 degrees. So this is an option in growing patients, as we will see with this case that was also kindly a courtesy of Dr. Giuliano Maino from Italy. So we can see a young hyperdivergent patient. He was 13, still during growth. He was a class 2 patient with a significant anterior open bite, and Dr. Giuliano decided to treat him with 4 mini implants on each quadrant, pulling the posterior teeth up with the intention of reducing posterior alveolar height. He also had to extract premolars in the lower arch because this patient didn't have lateral incisors, upper laterals. So the literature states that opening or closing 1 millimeter in the molar area, you will have approximately 2 degrees of mandibular plane change. And this was his final result, a significant closure of the bite with an adequate occlusion and a very important vertical change of the occlusion. But despite the efforts of changing this mandibular plane angle in 4 degrees from 39 to 35, this is not very much expressed in the face as a surgical approach would be. So there is a limitation. We don't have an enormous alveolar height to do enough intrusion to be able to gain what a surgical rotation will give us. So these are things that we have to take into consideration when we are doing our clinical planning. But what about the short faces? Can we treat them during growth? Let's have a look at this young girl. Clearly a short-faced patient. Lower anterior facial height is short. This overclosure of the lips is very, very traditional in these patients. And it's something that bothers me very much. They age very badly. And lack of exposure of teeth, which is something that is also a big issue for these patients. She was a class 1 occlusion with a deep bite. And when we put these diagnostic factors together, what are we going to do? She has a decreased lower anterior facial height. She has no exposure of upper incisor, and she has a decreased posterior alveolar height. What can we do for her? With a decreased lower anterior facial height, we need to extrude molars. With the decreased upper incisor exposure, even though she is a deep bite, we will have to extrude upper incisors. And with the decreased posterior alveolar height, again, we have to extrude molars. So we didn't worry at the moment with the incisors, but decided to treat her with a fixed bite plate, allowing spontaneous extrusion of the posterior teeth. So here she is the day she placed the bite plate with a significant amount of opening of the posterior segment for spontaneous extrusion of these posterior teeth. And this is the immediate change in the face. You can see she even has a little bit of difficulty of closing her lips. 1 year with bite raise, and these are the facial changes. And despite my efforts of opening the posterior segment, we didn't see any changes in the anterior bite. She still is a deep bite, even though I opened her up quite a lot. So beginning after the during the bite raise, and 1 year after the bite raise. What happened to her? When we superimpose her CBCTs, we do see a rotation of the mandible, a clockwise rotation of this mandible, but we really cannot tell if this growth was changed because of the bite plate or if that would be her natural growth. The literature is also, again, very poor on the use of bite plates, even though we use it a lot. So the effects of bite plates were published in 1954, and they looked at 30 deep bite growing patients and 30 controls before and after the bite plate. They saw that the upper and the lower molar had an eruption rate increased, as we saw in our young girl. There was an opening of the occlusal plane, but despite the opening of the occlusal plane, there was no changes in upper incisors, just as we saw with our young little girl. But these questions still remain unanswered. And this is a project that I have been carrying on in an international collaboration with the University of Florence. We are looking at the facial and dental effects in early treatment of short-faced patients. And I hope that very soon, by the end of 2025, we can bring final results to you, because we will now have a control group and we will be able to compare the outcomes. Nevertheless, as I told you, the overbite wasn't corrected. And the overbite, or the amount of incisor overlap, becomes our fourth diagnostic factor when we are going to talk about the second aspect of vertical problems, which is the amount of overbite. Everyone in this room knows what a normal overbite is, that it should measure 1/3 of the incisor overlap, or approximately less than 4 millimeters. And when it is disrupted, it can go both ways. You can have an open bite or a deep bite. And these can be described in many ways, by measurements, by mild, severe, or moderate, by the amount of overlap. Choose whatever you want, as long as you describe it so that it can give you the clinical information of what you want to do. What we have to remember is what is really important in establishing an adequate overbite. It is important to give you something called anterior guidance, which will protect the posterior teeth from protrusive and lateral stresses. It will decrease the jaw muscles' activities, and it will decrease the force on the anterior teeth. This explains sometimes why aesthetic restorations fracture, because you don't have adequate anterior guidance. When you have it, there is a decrease in the force in the anterior teeth. So the main reason to correct an anterior open bite is because lack of anterior guidance will cause wear to posterior teeth. This is not bruxism. This is regular wear because of lack of anterior guidance. And, right there. And the reason we have to correct deep bites is you can either have gingival impingement, or because you have a long excursion until you have muscular relaxation, you will end up causing incisal wear. So how are we going to deal with overbite? Let's have a look at this patient. Obviously everyone is seeing her anterior open bite right there. She had good facial proportions, a good lip seal, but a significant inverted smile line and a very, very large anterior open bite. She was a class 1 patient with a cross-bite tendency on the left side and a significant anterior open bite with a large overjet. So let's put one more clinical or diagnostic factor in our analysis. We have an mildly increased lower facial height. We have no incisor exposure, and we have a mildly increased posterior alveolar height with an anterior open bite. So these diagnostic factors are increased lower anterior facial height. We need to intrude molars. A decreased upper incisor exposure, we need to extrude incisors. An increased posterior alveolar height, we need to intrude molars. And a decreased overbite that can be corrected by extrusion of both upper and lower incisors. So this is what we're going to do. We're going to correct the transverse problem using rapid maxillary expansion. We are going to intrude molars using mini implants with a continuous arch wire. If you have a continuous arch wire and you're pulling the posterior segment up, the anterior segment is going to rotate and you will extrude upper incisors. You're going to rotate the occlusal plane. And, and we are going to extrude lower incisors with vertical elastics to finish up the anterior open bite. And remember, every time you see an anterior open bite, there is a functional component, so some sort of tongue mechanism has to be placed, a crib or spurs or whatever you prefer. But this is her final result, treated the way I proposed. This is her final facial characteristics and what happened to her. We were successful in intruding her molars. This led to, as I told you, incisor extrusion, which improved her upper incisor display at rest, a counterclockwise rotation of the mandible with lower incisor extrusion to this final result. What we did really is a rotation of the upper occlusal plane, intruding molars and extruding incisors. She had tongue spurs all along the treatment, by the way. And this rotation improved incisor display and the smile line, as you can see. Now let's go the other way around. Let's go to the short faces and the deep bites. This patient had a mild short or decreased lower anterior facial height with good lip seal and very limited amount of dental exposure, difficulty in showing her teeth. She was a class 2 with a deep bite and severely retroclined upper incisors. So let's put our diagnostic factors all together. She had a decreased lower facial height. She had excessive upper incisor display at rest and a decreased posterior alveolar height. So these diagnostic factors leads us to a decreased lower facial height, which will improve if we extrude molars. An increased upper incisor exposure that will decrease if we intrude incisors. A decreased posterior alveolar height that will improve if we extrude molars. And an increased overbite that will improve if we intrude upper and lower incisors. So this is what we planned. We planned to procline upper and lower incisors, which would give us relative intrusion, and we would extrude molars with bite raises and class 2 elastics, which would forcefully extrude molars anyway as a side effect. And this would give me a clockwise rotation of the mandible and an increase in anterior facial height. So here she is after treatment. You can already notice the increase in facial height, better lip sealing, and more dental exposure. This is the final result for correction. She's a good class 1. You can see the amount of protrusion of these incisors and the correction of the deep bite. What happened to her? Extrusion of molars, which led to a clockwise rotation of the mandible and an increase in lower facial height, and the proclination of incisors, which led to relative incisor intrusion and therefore the correction of the deep bite. And also improvement of the excessive incisor exposure at rest. So really, we are achieving here facial changes, occlusal changes, but also smile aesthetic changes, gaining now a consonant smile line and reduced lower incisor display due to lower incisor intrusion. And we're going to go now finally to our last and third aspect that can affect the vertical dimension. For me, this is the hardest one. It's the occlusal vertical dimension. And this can be affected by our fifth diagnostic factor, which is occlusal wear, which will lead to reducel in crown height. So loss of occlusal vertical dimension can happen either by carious destruction or by non-carious destruction. And the non-carious destruction is what will destroy the occlusal surfaces of posterior or anterior teeth by either wear or chemical destruction or chemical etching. Occlusal vertical dimension is a prosthetic concept. You've seen me show this slide many, many times, but it is very, very important because we deal with this as orthodontists all the time, and we sometimes forget we can use this at our favor. The occlusal vertical dimension is the vertical distance between the jaws. There is a rest vertical dimension when we are not with these jaws in maximum intercuspation, and the difference between these two measurements is the interocclusal distance, also known as freeway space. So let's have a look at this case. Hyperdivergent patient, a senior patient with good lip seal and a high lip line, a high smile line. She had severe caries destruction and couldn't be rehabilitated. She came to me with that remark. She was a class 2 patient with a deep bite and a large overjet. And when we look at this patient cephalometrically, she is a hyperdivergent class 2. She already had a chin prosthesis. She had good upper incisor display at rest of 3 millimeters, an increased curve of Spee, and on top of all of that, she was diagnosed with osteonecrosis. Because she had osteonecrosis, a clearly surgical patient could not be treated invasively. So how can we work with her at our favor? Let's go through our diagnostic factors. She had an increased lower anterior facial height, good upper incisor display at rest, increased posterior alveolar height, and occlusal wear. So we could define a maxillary impaction. Because of osteonecrosis, I couldn't do it. For good upper incisor exposure, we should just leave it. Increased posterior alveolar height, we could intrude these molars with mini implants, but she had osteonecrosis, so I couldn't do it. And finally, an increased overbite that had to be corrected. We could intrude lower incisors by correcting the curve of Spee, but is that enough? And she had decreased crown heights in the posterior segment. So we need to restore the lower molars. And this would give us an increase in occlusal vertical dimension and help me treat this patient. So this is what we did. We did restorations in the lower arch, which led her to a worsening of the class 2. Remember, every time we extrude, we're going to rotate and make the class 2 worse. And we leveled her out just with regular appliances and some class 2 elastics to this final result. And we can see that we did worsen her face a little bit. Her smile line is still high. We didn't do any surgical procedure, but we did correct her using the prosthetic increase in occlusal vertical dimension, which led to a clockwise rotation of the mandible, but allowed us to level out this lower arch. We extruded a little bit the upper incisors and had minor effects on her smile. So the beginning, after the restorations, and at the end of her treatment. Now what happens when we have anterior wear? This young boy presented a bimaxillary facial profile with a class 3 tendency, and his smile is only of lower incisors. We have a severe vertical dysplasia right there. He was a class 3 patient with an edge-to-edge anterior relationship, which led to significant wear of incisors. And when we analyzed the exposure of these teeth, he had a significant amount of exposure of lower incisors to the point he exposed gingiva of the lower arch. How are we going to treat this? Let's have a look at our analysis. He had an increased lower facial height. He had excessive exposure of lower incisors and no exposure at all of upper incisors, and an increased posterior alveolar height. Diagnostic factors, when we have wear, they go a little bit awkward. So we could intrude the molars, but he's a class 3, isn't he? If we intrude the molars, we're going to rotate him forward and get the class 3 worse, so that's a no. He's got a decreased upper incisor exposure and an increased lower incisor exposure. We can extrude upper incisor, but he has wear. We need vertical space to restore, so we can't do that. But we can intrude lower incisors. Okay. We have increased posterior alveolar height. We could intrude the molars, but he's a class 3. We would forward rotate and make him worse, so we can't do that. And he has a decreased overbite. We need to open this bite, so we could extrude upper incisors, but he has wear again, so we can't do it. So what ends up being the secret to correct this patient? We have to intrude these incisors and restore the wear. So every time you have wear, these diagnostic factors go awkward because you need to create vertical anterior dimension for restorations. So this is what we did. We used an upper bite plate and class 3 elastics so we could open him up a little bit more so we had some vertical anterior space. And then we restored him partially on the upper arch and placed mini implants on the lower arch so we could further intrude the lower incisors and create a vertical leeway that could give me space for anterior restorations. So this is what we did, and the results were some molar extrusion, which really didn't affect much his face, lower incisor intrusion giving us space for restorations, upper incisor intrusion to also give us space for restorations, and this is the study for his prosthetic rehabilitation. So this young boy received a full prosthetic rehabilitation in upper and lower arches so that he could gain a young, youthful smile line. Changes were dramatic. From an old man, he became a 21-year-old man, which he was. He was a dental school student, by the way. So changes, just by changing the vertical dimension, are possible of giving us significant space in the anterior region to change the faces, the smile completely. So really what I'm proposing here, and I would like to now drive us into ideas that we can conclude together. The vertical problem can involve 3 aspects: inadequate facial proportions, overbite, and occlusal vertical dimension. And unfortunately, these aspects have no common association to each other. Therefore, it's really not a challenge. It's just misunderstood. And we have to read the signs so that we can create an individualized treatment plan. That we are going to use basically 5 diagnostic criteria to establish a treatment plan that will include facial changes, occlusal changes, and smile changes, because this is what we want as an orthodontist. So putting all of this 1 hour together sums up to what I would really like to share with you today: a checklist for diagnostic factors that will help you establish your individualized treatment plan for your vertical patients. So we will include lower anterior facial height, incisor exposure, posterior alveolar height, overbite, and occlusal wear. If it's increased, normal, and decreased, and in the bottom line, what kind of treatment are you going to do? So I brought one last case, which would be supposedly an easy case, but it is not, so that we can apply the checklist. A short-faced patient with good lip seal and a small or short smile line. She presented a class 1 occlusion with a deep bite and some diastemas. And you're probably thinking, Flavia, it's a very easy case. But when we put the diagnostic factors together, thinking about the face, the occlusion, and the smile, it doesn't become that easy. And I sort of play around with my students, telling them, when sometimes you think it's easy, I make it look hard. So when we put the diagnostic factors together, we have a decreased lower anterior facial height. We can perform molar extrusion. We have a decreased upper incisor exposure, and even if she is a deep bite, we will need to extrude these incisors. We have a decreased posterior alveolar height. We will extrude molars, but we have an increased overbite. So if I know I have to extrude upper incisors, I will have to over-intrude lower incisors so I can change this vertical position of the anterior teeth. And this is what we're going to do. So we're going to place this in the graph or in the chart. So we have a decreased lower anterior facial height. What can we do? Increase it with molar extrusion. We have a decreased upper incisor exposure. We should extrude upper incisors. We have a normal lower incisor exposure, but we can further decrease it because it can be less than 0. We have a decreased lower posterior facial height or lower alveolar height. We can extrude molars and increase the facial height, and the overbite is increased, and we can further intrude the lower incisors to correct the deep bite. So this is what we did. We extruded molars, and we significantly intruded lower incisors through pluckination so we could have some vertical space to extrude incisors, improving significantly her occlusion and her bite, and giving her some more tooth exposure so we could improve her smile line with adequate upper incisor display at rest. So the checklist for vertical problems has the intention of making us put together diagnostic factors that would include the face, the occlusion, and the smile. And my intention here is use it creatively. There are no rules. Place values if you want, place norms, put arrows, cross things that you don't want to do, but use it so you can organize these diagnostic factors, which are sometimes disconsidered or sometimes misunderstood. It's just like words. Words that are placed randomly on a piece of paper mean nothing. Place is styled up proper. But when they are placed in the right order, they mean everything. Proper words in proper places make a true definition of style, and that is Jonathan Swift. Words are powerful things. They are our code for communication. Diagnostic factors are powerful things. They are our code to unveil an adequate treatment plan. They are the ones that establish or express our ideas. But in our job, when we deal with health and the human being, there's much more than just ideas when we are striving for excellence in results. So listen carefully to what Robin Williams has to tell us. No sound?
The world. See that look in Mr. Pitt's eye?
Let me go back. No sound?
Words and language. No matter what anybody tells you, words and ideas can change the world. Now see that look in Mr. Pitt's eye?
Can you put higher a little bit more,
like
please?
19th century literature has nothing to do with going to business school or medical school, right? Maybe. Mr. Hopkins, you may agree with them thinking, yes, we should simply study our Mr. Pritchard and learn our rhyme and meter and go quietly about the business of achieving other ambitions. A little secret for you. Huddle up. Huddle up! We don't read and write poetry because it's cute. We read and write poetry because we are members of the human race, and the human race is filled with passion. Medicine, law, business, engineering, these are noble pursuits and necessary to sustain life. But poetry, beauty, romance, love, these are what we stay alive for. That you are here. That life exists and identity. That the powerful play goes on and you may contribute a verse. What will your verse be?
So whatever your verse will be, to reach excellence, may it be written always with passion. No matter what life does to you, no matter the choices you make in your life, work every single day with passion. That will lead you definitely to excellence. And with this, ladies and gentlemen, I thank you very, very much for your kind attention. It was a pleasure to be with you here this morning. But before I leave the stage, with the authorization of the AAO, I would like to invite you to the 10th International Orthodontic Congress that will be happening in Rio de Janeiro in October 2025. This is the QR code that will lead you to registrations. And if you did enjoy the checklist, please give me good grades. Thank you very, very much for your kind attention.